Today we've got our continuation of the blood vessels PowerPoint. In the first blood vessels PowerPoint, we just kind of listed the arteries and the veins, and I kind of drew some of the differences between arteries and veins, and we found them on the model. So I'll be glad to review that again. The quiz about blood vessels is up on D2L. I think it's already been up, but it goes away on the 24th of February, so in a couple of days. If there's questions about that, I'll be glad to jump into that. And like I mentioned, the lab list isn't new, but we can once again hunt down those blood vessels if you weren't here to catch that stuff last time. Looking ahead to Thursday, if we complete everything today, Thursday will just be question and answer for exam 2. I'll be glad to redraw relevant things from our second unit like cardiac action potentials. We drew the EKG, and then we have a couple of things that we're going to draw today in terms of blood vessels. Like I said last time, our blood vessel discussion was mostly anatomy of locating those blood vessels, and today we talk more in the physiology realm about capillary exchange. So I've kind of started a little bit of a diagram over there that we'll probably go over there and fill that out a little bit further. But just a heads up, because I'm sure I'll have to erase this to make some room for another thing that we're going to draw. But blood vessels today, review on Thursday. I'll set up a practice practical also on Thursday that will be very similar to the real practical. It's going to include heart models and blood vessel models. Any questions about our to-do list? I'm going to go ahead and get that out of the way if that's okay then. Anyway, where was I at? If you're just coming in here, I just erased the to-do list. It is just a continuation of our blood vessel PowerPoint. We went through finding arteries and veins from the lab list last time, so there's nothing new in terms of lab. What we really get into that's new today is talking about capillary exchange. So just in time, we're about to go start with some physiology terms on the left, and I've cleared some space for another diagram that we're going to draw. So jumping into the slides, we saw this one last time, and where we are really going today is into capillaries and thinking about capillary exchange. Reviewing stuff from last time, we talked about how there were three layers on the artery and 3 layers on the veins. We talked about the differences between arteries and veins, the fact that the artery has a very small lumen that is round because of the high pressure. The vein has a much larger lumen that is not completely round. It's got much lower pressure due to the large volume. Another difference is there are valves in the veins that prevent backflow, and we don't really see that on the artery side. Another difference was the thickest layer in the arteries was the tunica media. The thickest layer in the veins was the tunica externa. So we're just kind of recapping artery and vein things that we mentioned last time. And we didn't spend much time on capillaries in our discussion, other than the fact that we talked about that they were a single layer of cells that were those squamous shaped cells, so they're very thin. And that's going to make them leaky. I talked about how, I might be too far away at this point. I talked about how in capillaries that more things are going to leak out of the capillaries than are going to be pulled back into the capillaries. And I'm trying to do a simplified diagram of that over here. Let's, before we fill this in, write some terms down that are going to be helpful to remember. When we refer to capillary exchange, we're going to see at different ends of this capillary, at the arterial end and at the venule end, there are going to be different pressures that we're going to be aware of. The first one that we'll talk about is hydrostatic pressure. And we can always remember hydrostatic pressure is going to be a pushing force. Hydrostatic pressure comes from the fact that your heart is pumping blood and it's pushing blood through those vessels, and that pushing force is hydrostatic pressure. It wouldn't be unlike if I had a fire hose that I turned all the way on full blast and water is trying to come out of that fire hose. That pushing force against the wall of that fire hose is a hydrostatic pressure. The opposite of a hydrostatic pressure is what we call osmotic pressure. This is a pulling force. And I think I talked about this osmotic pressure last time. I bet I still have in here. Yep. nobody has to act as a water molecule, but these are old things that I made. This is just a piece of paper that I wrote potassium ion, and I attached a couple of water molecules to it just to kind of indicate this pulling force that solutes have on water molecules. A potassium ion, wherever I take it, it's going to be pulling these two water molecules with it. Something much larger like a glucose molecule is going to be pulling 8 water molecules with it wherever it goes. So this pulling force, anything large like a plasma protein, I stuck kind of the maximum number of water molecules on this thing. This has a very strong osmotic pressure. When we were talking about plasma proteins in the blood, that was on the concept map of blood, we talked about plasma proteins. They made up 8% of the plasma. And the most common of those plasma proteins were albumin. They made up 60% of the plasma proteins. And their main job was maintaining that osmotic pressure of the blood. So we know inside the capillaries, there are going to be these plasma proteins. Not that that's a great example of a plasma protein, but that's going to be one of the things that maintains this osmotic pressure of the bloodstream. I didn't draw it over here, but we know that on the arterial end, there's a heart that's forcing blood down this vessel. So there's already this pushing force. And maybe the first thing that we can draw on here is the fact that when we're over here at the arterial end, the hydrostatic pressure, maybe I can just draw it this way, the hydrostatic pressure is going to be much larger than osmotic pressure. So when you have this pushing force that wins the battle, what happens is things are going to end up being pushed, squeezed out of these vessels. When this pushing force wins out, when things are squeezed in between those thin cells of the capillary, this is what we call filtration. I just want to make a distinction between filtration. When we get somewhere towards the middle of this capillary, we're going to see that hydrostatic pressure is about equal to osmotic pressure. So there's really not much capillary exchange that's going on right there in the middle. But as we get further from that arterial end, we're further away from that pump. So this hydrostatic pressure is going to become smaller and smaller. And instead what becomes the larger force in this case is going to be the osmotic pressure. So if osmotic pressure is kind of winning this battle, which it does towards the venule end, what we're going to see instead are going to be things moving into the blood vessels. This is what we're going to call reabsorption. Reabsorption, because it was already in the bloodstream, it just left the capillary temporarily and was hanging out in this stuff that we called the interstitial fluid. Try that again. Left one. Interstitial fluid, just like the interstates run in between states, so interstitial fluid is the fluid in between cells. If I'm going to abbreviate it, I'll keep the same abbreviation that we've been using for the fluid in between cells, and that's extracellular fluid. Maybe it might be helpful for me to draw just a couple of body tissues. Here's a body cell, and here's another body cell. We've got this fluid in between cells. And that fluid we're going to see is either going to be receiving stuff from the capillaries. At the arterial end, filtration is going to dominate. And at the venule end, we're going to see reabsorption is going to dominate, going to be the dominant force of osmotic pressure over hydrostatic pressure. Well, at least that's a good start. I'm trying to think if there's anything else. Let's get through a couple of slides, and then we'll put some numbers to that. What this slide shows is that there are going to be a bunch of lymphatic capillaries always tangled up with our normal capillaries. I have this thing labeled as a systemic capillary, just meaning that's part of the systemic circuit. That's why the arteries are red and the veins are blue. That's always the case in the systemic circuit. The colors are opposite in the pulmonary circuit. Anyway, systemic capillary, we can see it receiving that oxygen-rich blood from the arterial end, and we've got oxygen-poor blood being pulled into this venule end. What leaks out gets picked up by those capillary vessels I think lymphatic system is when we start Unit 3. We'll likely see this picture when we talk about the lymphatic system. Again, just pointing out what I was trying to mention with this little arrow here, and that is wherever we have our capillaries, whether that's the pulmonary capillaries or the systemic capillaries, there are going to be lymphatic capillaries that pick up that excess fluid. They cleanse that fluid. It passes through lymph nodes. T cells and B cells take out any pathogens that are in that fluid, and then that now cleansed fluid is going to return right back into that superior vena cava before it enters the heart. So the lymphatic system, one of the things that it helps do by picking up this excess fluid and returning it to the blood vessels is it maintains blood volume. And we've been talking a bunch, at least once, maybe about how blood volume is always directly related to blood pressure. Might be worth mentioning because we're going to go there at the end of this lecture and talk about how is blood pressure maintained by the body. And one way that the body can maintain blood pressure is by maintaining blood volume. Right there. That's a little better. There's a direct relationship between the two. Speaking of blood pressure, we saw a chart that looked something like this last time, and it was showing the difference in pressure in the ventricular walls when the ventricle is in its contraction phase, in its systole phase, or in its relaxation phase, the diastole phase. That's the slide that I just skipped over. So systolic pressure is when the ventricle is contracted, and diastolic pressure is when the ventricle is relaxed. So when we go and look at that left ventricular wall, you can see there's a huge fluctuation in pressure when it's either contracted or relaxed. And if we look at those elastic arteries, they too have this rebounding pressure of after ventricular systole, they stretch and expand out to accommodate that extra volume of blood, and then they recoil, and that helps push blood through these vessels. Where we're going in our lecture today is right here in the capillaries. And like I was trying to show over there with my little abbreviations, that when we are closer to the arterial end, there's higher pressure than when we consider the venule end of the capillary. So that additional hydrostatic pressure is going to help push things out of the vessels closer towards the arterial end. And we lose that pressure at the venule end. But the thing that really changes here is the hydrostatic pressure. That pushing force drops off as we go from the arterial end to the venule end. But let's go through a couple of more terms real quick, and then we'll draw this stuff on the board. Blood flow is just going to be the volume of blood that is passing through a vessel per unit of time. That is kind of a general definition, but what I like about this slide is it shows you visually that this vessel has more blood flowing through it than the top vessel. And if we think about what is different between these two vessels, in this first vessel we have at the beginning end of the vessel and the end of the vessel a difference in pressure of only 40 millimeters of mercury. So we have higher pressure at one end, lower pressure at the other. Blood flows from high pressure towards low pressure. And it flows faster if there is a steeper gradient. So here in the first vessel, we have a gradient of only 40 millimeters of mercury. In the second vessel down here, we start off at the beginning end of the vessel at 90 millimeters of mercury, and the other end of the vessel is at 10 millimeters of mercury. So there's a much steeper gradient here, and blood is going to flow much faster through this particular vessel. This is an equation. You aren't going to have to do blood flow equations on here, but this is just simply trying to show you, I guess that's what is responsible for additional blood flow through here. We're going to talk about the things that can affect blood flow and that can prevent blood flow. The opposite of blood flow is going to be what we call blood resistance. We can define this as the opposition to blood flow. And there's three things that factor into this resistance. The most influential of these factors is the highlighted one, so I'll just give that away. The diameter of the vessel is going to have the greatest effect on the resistance of blood flow. We've kind of been saying this already for 2 semesters now, that the blood vessels can change diameter, and that affects how much blood flows through them. That if we want to increase blood flow, those blood vessels increase diameter, vasodilation. increases blood flow. If we want to restrict blood flow, then we constrict those blood vessels. That's our vasoconstriction. This reduces the amount of space that blood has to flow through that vessel. If you think about it, it's dragging against the walls of the vessel. This increased resistance reduces blood flow. There are two other things that can reduce blood flow. Blood viscosity. If you eat a big salty bag of potato chips and don't get a drink of water, then your blood is just becoming more and more concentrated with those solutes, and that's going to make the blood become more and more viscous and harder to pump. Another thing that we'll see is that the length of the vessels is something that the longer the vessels are, the more resistance there is. We kind of saw something about this when we did the heart dissection last time, that the left ventricle has to pump blood greater distances through longer vessels. And so the left side of the heart is much larger than the right side of the heart. That right ventricle wasn't very thick because it was only pumping blood to the lungs that were right there, a much shorter distance. Okay. Thinking back to last semester, what I was talking about when we were seeing this is that it's only the sympathetic nervous system that controls most blood vessels. And we said that sympathetic nervous system has its foot on the accelerator just slightly, just enough to cause a slight constriction. That slight constriction is what we call vascular tone. And that sympathetic nervous system can slam further down on the gas pedal, increase that sympathetic signal. That's going to increase the vasoconstriction, or it can let its foot off the gas pedal. And decrease that sympathetic signal. That would cause the blood vessels to dilate. So it's the sympathetic system all by itself that can control constriction or dilation of most of these blood vessels. I say most because the only exceptions, like we said, were in reproductive tissues, erectile reproductive tissues. This is a picture that's just trying to show the same thing. The factor that had the greatest effect on blood flow was the diameter of the vessel. So we can see a small diameter vessel has less blood flow through it, and one way that we can drastically increase blood flow through a vessel is to increase the diameter. So vasoconstriction and vasodilation are going to be one of the main ways in which we shunt blood around into different capillary beds. We saw this last time. It's just a picture of a capillary bed that is now full of blood because those sphincter muscles around it have relaxed. That vasodilation has allowed for blood flow to these particular capillaries. We're going to look to see what kind of capillary exchange has taken place in just a second, but we remember if those same blood vessels were constricted, then it's going to prevent any blood flow from moving into those particular tissues, and instead that blood is going to go into other organ systems. Now to the fun stuff. Let me see. That's the same thing. I just added these additional pictures right here, and I kind of really didn't need to for our particular class because I have this thing written on the board. I've got a cross section of our capillary. We can see how it's a single layer of cells that are just close enough together that if there is high enough pressure in this vessel, things can leak out. So we said leaky vessels is filtration. And if there is a pulling force greater than if the pulling force is greater than the pushing force, then at the venule end, we're going to see a reabsorption occur. That's what this little picture is just trying to show us. At the arterial end, the BP in this case is blood pressure. So you have to really kind of connect the dots that blood pressure, that pushing force of blood through the vessels is our hydrostatic pressure. That pushing force is greater than the osmotic pressure, that pulling force of the blood vessel. So at the arterial end, we're going to see more filtration than reabsorption. Nothing much happens in the middle, but over here at the venule end, we can see that it's the opposite. We're further away from that pump. So the blood pressure, that pushing force, has been greatly reduced, but the osmotic pressure, that's now greater than the pushing force, so there's an overall reabsorption at this venule end. That's what this graph is trying to show, and I guess we can set this up with some pictures. And there's a couple of different ways we can do this. I will try it this way. I'm going to try and take that diagram. In fact, let's just steal some of these colors. I will use this purple color to draw a capillary. Hopefully that's enough of a capillary that we can see. And then out here, I'll just put a couple of cells like we had over there on the board. Label this body tissues, and we know in between those body tissues is where we would find that extracellular fluid. I'll just label that this ECF, or extracellular fluid. We talked about cardiac physiology last time. So just to remember things that we mentioned last time, we know that on the outside of cells there is very little potassium ions, but there's a little bit. We're not really concerned so much with this lecture with what's going on inside the cell, but we know outside of the cell there's lots of sodium ions. And I guess I'm just reminding us of this to mention that this extracellular fluid, it does have ions in it. And ions, like I was just trying to show us, they have a pulling force on water molecules. So wherever we find these ions, they're going to be pulling on water. Inside the capillary, just kind of to flash back to things that we were talking about in Unit 1 when we were talking about the blood. I had a couple of them drawn in there. One of those things we find in the blood is the plasma proteins. And also in the bloodstream there are things like glucose molecules. If you eat a sugary snack or something like that, then you've got a bunch of glucose. There's plasma proteins that are in there. We already know there are plenty of ions like the sodium ions and potassium ions. We could include calcium ions. Just things that we've mentioned recently. Not to even mention the red blood cells, white blood cells, and platelets. There's plenty of substances inside the plasma that are going to exert this pulling force. So the capillary itself is going to have an osmotic pressure. We're going to mark that as osmotic pressure of the capillary. Hopefully we can see that just as capillary. And remember that this capillary is hooked up to a beating heart. So there's also a hydrostatic pressure of the capillary. And we were just talking about this extracellular fluid. This extracellular fluid also is going to have its own, we'll say, hydrostatic pressure and osmotic pressure. I'm going to mark the osmotic pressure of this extracellular fluid. This, you see it is marked in here as an IF. The I stands for interstitial fluid. I'll just stick with that. So IF is our interstitial fluid, this fluid in between the cells. We have our four forces. In fact, the very next slides are about these four forces. But I just want to do one other thing over here, and that is, I'll say this. Any of these forces that we're talking about that favor filtration, they're going to get a plus sign next to them. And any sign that does not favor filtration, that instead favors reabsorption, is going to get a negative sign next to it. So again, filtration just means things are pushed out of the capillaries into this extracellular fluid. So let's do this real quick, at least once. This hydrostatic pressure of the capillary, it's pushing, that's the pushing force that's trying to push things out of the capillary. We're going to mark this, I'll just keep the same color here. We're going to mark this hydrostatic pressure with a plus, little plus sign, meaning that that is a force that is favoring filtration. It's trying to push things out of the capillary. The osmotic pressure of the capillary, that's going to oppose filtration. Because again, water molecules are going to be attracted to the glucose and the plasma proteins and all of that stuff. Remember, we said something at one point where I talked about the commercials that come on late at night where in those developing countries you have kids that are severely malnourished. They don't have protein in their diet, so their body can't manufacture plasma proteins. They don't have any the proper amount of plasma proteins in the bloodstream. That's the main thing that holds on to water molecules in here, and without those plasma proteins, water molecules leak out. That pushing force wins out. There's not enough pulling force, so water leaves the capillaries. You see the swollen bellies and that edema. Anyway, osmotic pressure of the capillary, this is opposing filtration because it's trying to pull things back into the capillary. We doing good so far? Let's talk about interstitial fluid forces. These are kind of easy. The hydrostatic pressure, again, hydrostatic pressure is a pushing force, and there is no pushing force out here. There's no heart in the extracellular fluid that's pushing things back the other direction. So when we put numbers on this, the number that's typically associated with this hydrostatic pressure is 0. It typically doesn't have any kind of effect, but I have to say typically, because what happens in some cases, there was my aunt has bladder cancer. She's got a friend that had this type of breast cancer where she had to take a lot of the lymphatic tissue out of her right arm. And that meant, well, like we just said earlier, lymphatic tissue helps pull excess fluid that leaks out of the capillaries. It picks up that excess fluid. And so without that lymphatic tissue, this person had a right arm that was constantly more swollen than it needed to be. There was a buildup of extracellular fluid. There wasn't any lymphatic tissue to remove that buildup of extracellular fluid. So if you're in one of those types of situations where there is a buildup of extracellular fluid, then this pushing force could end up actually starting to register numbers. If it does register numbers, this is the pushing force that's going to be pushing back against the capillary. So should it register any number, this is going to oppose things leaking out of the capillary. It's going to oppose filtration because it's pushing against filtration. Typically, this number is going to be a 0, so it's not going to have any effect unless, like I said, there's a buildup of extracellular fluid. Then things might actually start to push back the opposite direction. Now, osmotic pressure, we know that's a pulling force, and there are some ions out here in the extracellular fluid. Water would be attracted to these ions, so there is a slight pulling force of this extracellular fluid. This is going to be a small number when we put numbers to this, but any number out here is going to favor filtration. It's going to favor pulling things out of the capillary into this extracellular fluid. So we're going to put a positive sign next to that. Still doing good? I think we are now ready to move forward in some of the slides. And this should be the same thing that we just listed. When we're thinking about that hydrostatic pressure of the capillary, there's my pointer, I'd mentioned that this pushing force is really a result of the fact that the heart is constantly beating and it's forcing blood through those arteries. So at this arterial end, there's more of this hydrostatic pressure, more of this pushing force. We'll put numbers to this in a second, and just by the numbers, we'll be able to tell whether we are at the arterial end or whether we are at the venual end, because the numbers are going to tell us whether things are coming out of the capillary, arterial end, or moving back into the capillary, which would be venual end. Hydrostatic pressure, again, outward pressure, it favors filtration. It's due to the beating of the heart. The second force that we mentioned is the osmotic pressure of the capillary. This is wanting to pull things back into the capillary because there are solutes in there, glucose and plasma proteins. So the picture is just reminding us that there are solutes in the capillary, and that wants to pull things back into the capillary. That would oppose filtration because, again, it's working opposite of filtration. Here we have that hydrostatic pressure of the interstitial fluid. I said this is typically a 0 because there's no pushing force out here in the extracellular fluid unless there's a buildup or a swelling in this extracellular fluid. It opposes filtration because if there is a buildup of fluid out here, it's going to want to push things back against the capillary. And then the final force that we introduced there is this osmotic pressure of the interstitial fluid. And you can imagine if somebody that is in hyperkalemic, is something that we talked about earlier. So if you have a buildup of excess ions in the extracellular fluid, that's going to increase this number. It's going to increase the pulling force of that extracellular fluid. That would favor filtration. It's important to kind of mention these things at least once. We're going to see all of these forces again when we get into the kidneys. And we're going to draw this same picture of a capillary into the kidney, and we're going to draw this structure called Bowman's capsule that surrounds capillaries in the kidneys. And we'll talk about the forces that pull things out of the capillaries or prevent filtration from occurring in the kidneys. If filtration can't occur in the kidneys, then the cells are drowning in their own waste, and it can become fatal very quickly. So we'll need to follow the numbers to see how easy is it for filtration to occur or the opposite. Okay, now I can draw what's going on in the capillary, and we can kind of see what's going on in this interstitial fluid. So at the arterial end, what I was just about to put is the hydrostatic pressure inside this capillary is typically about 37 millimeters of mercury. And we know this hydrostatic pressure is we put a plus sign next to it because it favors filtration. It's going to want to push things out of the vessel. And the osmotic pressure of the capillary here at this arterial end is about 26. But we know this osmotic pressure, it opposes filtration, so I'm going to put a negative sign next to it. We're doing great so far. Now, if we look at the extracellular fluid, all of this stuff outside of the capillary, close to the arterial end, we're going to see that it too has a hydrostatic pressure and an osmotic pressure. The hydrostatic pressure, like we said, it's going to be pushing against the capillary, so if it registers anything at all that opposes filtration, this osmotic pressure out here in the extracellular fluid is a pulling force. It's going to want to pull things out of the capillary, so it's our positive number. It's important to get those right, but like we said, out here in the extracellular fluid, this hydrostatic pressure is typically 0. So it's not going to measure any number. There's no pump out here. So only if there was a buildup of extracellular fluid due to swelling or something like that would this actually register a number. Osmotic pressure, like we can see over there in the other diagram, surrounding these cells there are ions like potassium and sodium and calcium ions. So this extracellular fluid does have a little bit of a pulling force to it, but that is very small. I'm going to give it a number of 1. We're done with the numbers. Let's try and go up here and do some math. So we've got at the arterial end, we've got our hydrostatic pressure of 37. That's a positive number. So a positive 37. We've got a negative 26. Then the hydrostatic pressure out there, that's a negative number, but it's a 0, so that's not changing much. And then osmotic pressure, that's another positive number. So if we do this, we've got 38 minus 26. Maybe you can tell me if my math is correct, but I think my head is telling me that that's a plus 12. You might check me on that. Should be a positive number at least. Plus 12. This is what we do. We crunch these numbers. And if the ending number right there is a positive number, that tells us that filtration, that positive number, wins out. Things are going to be leaking out of the vessels. But look what happens when we move over towards this venule end. At the venule end, I'll use a different color. The only number that changes is this hydrostatic pressure of the capillary. We're getting further away from that pump. So let's rewrite the numbers over here. The hydrostatic pressure of the capillary drops off. This thing is going to go all the way down to 17. Still a positive number, but much lower. Then if we think about the osmotic pressure of the capillary, this is still the same. It's still 26. We said that opposes filtration, so we have our numbers in there. And then the numbers are still the same out here in the extracellular fluid. So hydrostatic pressure of this extracellular fluid or interstitial fluid is 0. that oppose filtration, but it's not measuring anything, so no big deal. Osmotic pressure of the interstitial fluid out here is still a 1. We said that opposes, what am I trying to say? That favors filtration. Everything still matches, but we've got different numbers up here. So let's go up here. We now have a +1 and a +17. So I'll say +1, +17, a total of +18. And then the other numbers we have, there is a -0 and a -26. So when we do all that, we get a -8. I'm not good at doing math in my head. Anybody confirm? Confirmed. All right, -8. So when we do the math here and we get a negative number, that tells us that overall the reabsorption forces have won out, and this thing is going to be like a vacuum pulling things into this venule in. It's a little bit of, laborious putting the numbers in there like that, but now that we've done that, if we go back to this slide and we see things like dehydration, how that's going to affect this, how that affects any of these numbers, really. We'll see that dehydration and a blood hemorrhage are going to have kind of similar effects on this. In a blood hemorrhage, you're losing vast amounts of blood volume. Just like in dehydration, you're so dehydrated that you're losing blood volume. And that's going to mean that blood pressure drops off. If we lose blood volume and we lose blood pressure, it's this hydrostatic, it's this pushing force number that starts to drop. And really, that's the only force that we have favoring filtration, that really favors filtration. So if we become severely dehydrated, or we're dealing with a severe hemorrhage where we've lost blood volume, our blood pressure may drop to the point that filtration is more difficult. Just to jump to heart failure too, this third one, heart failure. If your heart is failing, it's not pumping as hard, so this hydrostatic pressure, this number is becoming lower and lower. And it becomes fatal when the heart, again, can't pump hard enough that filtration occurs at the capillaries. Cells start to drown in their own waste. The second one, liver disease and severe malnutrition. These also are kind of two sides of the same coin. In severe liver disease, there's something wrong with the cells. They're not producing plasma proteins. So you don't have plasma proteins in the bloodstream. Those plasma proteins, if they are in there, they are the dominant thing that's maintaining osmotic pressure, pulling water into the blood vessels. So if you can't manufacture plasma proteins, then you lose this osmotic pressure of the capillary. This number would go down to like 10 if we didn't have the proper levels of plasma proteins. That number is so high due to mostly that albumin. So severe malnutrition, your body's just not getting the proteins that it needs to manufacture those plasma proteins, whether the liver could do it or not. So liver disease and severe malnutrition are kind of the same thing because they affect that plasma protein concentration of the blood, and that's the main thing affecting that osmotic pressure. Those are the main numbers because everything out here is kind of dependent on whether there's swelling or you're in a hyperkalemic situation. The next one is large amounts of histamines. This is what happens when you go to like anaphylactic shock. If your body goes into this body-wide vasodilation and your capillaries dilate to such an extreme point that these spaces in between cells become so large that plasma proteins can actually leak out into the surrounding extracellular fluid, that's kind of a double whammy because you lose this osmotic pressure of the capillary. That number goes down at the same time that this number goes up. So there's less things holding fluid into the capillaries and more things pulling that fluid into this extracellular fluid. That's, again, blood volume would drop so low that blood pressure is hard to maintain, and that can become fatal if you can't circulate blood to the brain. I mentioned earlier that lymphatic vessel blockage. If you've had lymphatic vessels removed, then there's going to be an accumulation of that extracellular fluid. Nothing there to reduce that extracellular fluid. And if it builds up too much, then we could start increasing that hydrostatic pressure of the interstitial fluid. Typically it's nothing, but if we were in one of those situations of a lymphatic vessel blockage, this number might start to increase. You can imagine if it was all the way up to like a 20, then that's going to be pushing back against the capillary. It's really going to make it difficult for filtration to occur. So maybe some of the higher level questions on the exam or the quiz might be thinking about how something like heart failure or liver disease or malnutrition might affect one of these particular forces, pushing force or pulling force. I'll leave this up. We can keep talking about it. But the next couple of slides take us into what I'd kind of talked about earlier, that the body is able to regulate blood pressure. If blood pressure drops too low, put this down. This blood pressure, this pushing force of the blood is the main thing, like we said, that favors filtration. So the body needs to be able to correct if this pushing force gets too low. So if blood pressure drops too low, we're going to see that the body has a snappy way of responding to do things that boost blood pressure. And again, blood pressure and blood volume are tied together. So anything that boosts blood volume also helps boost blood pressure. Both of those are going to tie into how the body responds to blood pressure being too low. What do we have here? We have some terms that refer to blood flow around the body. This mean arterial pressure just refers to the mean pressure that the arteries, that the blood vessels feel as blood moves through them. Mean arterial pressure is affected by two things. It's affected by cardiac output. We talked about that last time. Cardiac output was how fast the heart beats and how much volume the heart pumps per beat. So it was beats per minute and volume of blood per beat is cardiac output. This mean arterial pressure is going to be a factor of cardiac output and then peripheral resistance. Resistance to blood flow, like we said, the main factor that resists blood flow is the vasoconstriction or vasodilation of blood vessels. Vasodilation increases that blood flow, reduces resistance. Vasoconstriction is going to increase that resistance and reduce blood flow. Okay. Here are some questions, and I think I might have just answered the first one. How does the body change cardiac output? If you remember, cardiac output is heart rate and stroke volume. We pointed that out. Oh, I guess I didn't have the answer there. But the body affects cardiac output, we said, by sympathetic or parasympathetic nervous system. Sympathetic nervous system can affect both heart rate and stroke volume. Parasympathetic nervous system can affect just the heart rate by slowing down that heart rate. Next question is about how the body can change that peripheral resistance. I think I gave that one away also just in my words. They're talking that by either constricting or dilating these blood vessels, that's really going to increase the resistance or decrease the resistance. Much more blood flow through a dilated vessel than a constricted vessel. So we have to say radius of the vessel is the most important factor influencing resistance. There is the other factor of blood viscosity. So if you are diabetic and your blood glucose levels are really high, your blood is much more viscous and it's harder to pump. It's sticking against the walls of the vessel. It's like a motor oil. All right. Last thing is how does the body regulate blood volume? I feel like there's another question there about blood pressure. We know blood volume and blood pressure are two sides of the same coin. So here's where we mentioned some hormones from Unit 1. One way that the body can regulate blood volume is by holding on to extra salt. That hormone of aldosterone is what allowed the body to hold on to extra salt. When we draw the kidney tubules, we're going to see exactly which cells respond to aldosterone. They basically put these little protein channels on their plasma membrane that are permeable only to sodium. With these extra gates on it that sodium can travel through, there's extra ways for sodium to be pulled back into the bloodstream and not be lost in the urine. So holding on to sodium is one way that the body can boost blood volume. And like I was just talking about, if we hold on to a sodium, then it's going to be much easier to retain water because water molecules are going to want to follow wherever a sodium ion goes. So in addition to aldosterone, there's also antidiuretic hormone, which we will also draw when we draw the kidney tubules. Those same cells in the kidney tubules that can adjust the number of channels that they have for sodium can also adjust the number of channels that they have for water. So antidiuretic hormone is going to cause these cells in the kidney tubules to put a bunch more channels along their plasma membrane that are permeable to water. So it makes it much easier for water to be pulled out of the filtrate and back into the blood vessels. So by retaining salt and retaining water, that boosts our blood volume and is going to help boost our blood pressure. If we had too much blood volume or blood pressure, this, again, my dad is a diabetic, so he used to drink like Dr. Peppers all the time. They're full of sugar. And then he would go to the bathroom all the time too, because he's now drank a case of Dr. Peppers that has boosted his blood volume. It's full of sugar, so now that is going to be making him feel not only dehydrated, but it has boosted his blood pressure. So if the blood pressure is too high, one way we can reduce blood pressure is by reducing blood volume. That's why he was going to the bathroom a lot, to try and reduce that blood volume and bring that blood pressure down. So again, we will see that aldosterone and antidiuretic hormone, if we reduce aldosterone, we reduce how much salt we hold on to. And by reducing antidiuretic hormone, that reduces how much water we hold on to. Both of those things, by getting rid of the blood volume, is going to reduce that blood pressure. So we've got to be able to do both. I know I kind of just said this with the last slide, but I've got the answer here at least. The body's going to be able to regulate blood pressure by way of this renin, angiotensin, aldosterone system. Renin, angiotensin, aldosterone system. This is something that happens when the body's blood pressure gets to a crucial low level. Again, if it's too low, then there isn't enough of a pushing force for waste to be filtered out of the bloodstream. The kidneys aren't going to be able to produce any filtrate. Cells are going to start to drown in their own waste. So something has to kick in if blood pressure drops too low. And it turns out there are some cells in the kidney. Again, I'm really plugging this kidney lecture when we get into Unit 4. We'll draw the kidney, we'll draw the group of cells in the kidney that are able to sense when pressure drops too low. They respond, this group of cells in the kidney respond by producing a hormone, a chemical signal called renin. And I sure would like to draw what renin does, and I may have to in lab if this next diagram is not sufficient. There's a lot going on with this diagram, so I'll just stand over here and try and use my pointer to point at what's going on. If I need to draw this, I will. Let's start here with the liver. And the liver is like the liver does, it produces plasma proteins. And one of those plasma proteins is called Angiotensinogen. I talked about this earlier when we were talking about plasma proteins. If there is an ending on the plasma protein that ends in O-G-E-N, this is an inactive form of a protein. So angiotensinogen is a plasma protein that is inactive. It's produced by the liver. It's in your bloodstream right now. It's there all the time, and it's turned off. It's not doing anything. That's fine. But you can see angiotensinogen is going to become activated. It's going to be converted into its active form of angiotensin 1 by way of this chemical signal renin. Again, if this is confusing, I'll try and draw it on the board. I don't know that my drawing will be any less confusing. But this little part of the diagram is showing us that there's a patch of cells in the kidney that can sense if blood pressure drops too low. And if blood pressure drops too low, that's going to stimulate those cells of the kidney to start pumping out renin. So here is renin. It's leaked out of the kidneys. And what renin does is it converts this protein from its inactive form to its active form of angiotensin 1. This is only the beginning of the story. Angiotensin 1 doesn't really do much. This is now a protein that has been activated. It's moving through the bloodstream. It moves into the lungs. So there are pulmonary arteries that take this blood with angiotensin 1 in it, through the lungs. And in the lungs, there is an enzyme inside the lungs that is going to activate angiotensin 1 into its second form called angiotensin 2. That enzyme is called the ACE enzyme. It stands for angiotensin converting enzyme. Right? It converts angiotensin 1 to angiotensin 2. That's really kind of where the magic happens, because angiotensin 2, this is the active form of a protein that's going to do several things. All of these things that it does are going to act to boost blood pressure, to boost blood volume. It's going to counter the fact that blood pressure is too low. So anything that boosts blood pressure or boosts blood volume is going to help retain filtration rates. So you also see this if somebody has blood pressure that's too high. If you want to reduce somebody's blood pressure, they're typically put on ACE inhibitors. And an ACE inhibitor is going to inhibit angiotensin 2 from forming. So what we see angiotensin 2 is going to do, all of these things that it does, increases blood pressure, increases blood volume. So if you already have too much blood pressure or blood volume, you want to reduce the amount of angiotensin 2 that you have in your bloodstream. Let's list 4 things that this angiotensin 2 is going to do. The first thing that this part of the diagram is showing you is angiotensin 2 is going to stimulate the sympathetic nervous system. We know that the sympathetic nervous system is going to control most blood vessels, and it's going to cause those blood vessels to constrict. So this first part of the graph, as sympathetic stimulus increases and those blood vessels constrict, that increases blood pressure just due to vasoconstriction. They also kind of point to the same thing right here. So those arteries are going to vasoconstrict. That reduces the volume that they have. So blood pressure increases just to vasoconstriction. The other thing with sympathetic activity, heart rate increases, cardiac output increases, so there's more blood forced through those vessels. In addition to heart rate increase and vasoconstriction, you have things like the hypothalamus is told to not only start to pump out antidiuretic hormone and retain extra water. The more water we hold on to, the more we boost blood volume, which again boosts our blood pressure. The other thing that the hypothalamus does, which I don't know if it's mentioned here at all, but a signal is sent to the hypothalamus that increases your thirst. So you become thirsty, and that is going to, once again, increase blood volume. Drinking a gallon of water increases your blood volume, which increases your blood pressure. So hypothalamus is pumping out this antidiuretic hormone that retains water. It makes you thirsty, so you ingest more water. Your blood vessels constrict. That's another thing that boosts our blood pressure. And the other thing that we're going to list is angiotensin 2 is going to go to that adrenal cortex. And there are some of those cells in the adrenal cortex that pump out aldosterone. Again, that's where we hold on to extra sodium in the kidney tubules. And for every sodium that we hold on to, we said 3 water molecules are going to follow it. So really this retention of sodium and retention of water, those go hand in hand. So all of these things that angiotensin 2 is doing are increasing blood volume or blood pressure, and that's going to help maintain our filtration rates. I don't know if I have another slide past that, but if we need to draw this on the board in less words, we can do that. Let's see what we have. Oh, these are from the boxes from when I walked through this on the recording. Like I said, it starts in the kidney. If blood pressure drops too low, it's these cells in the kidney that can sense that. They pump out renin. We can see renin then is going to convert that inactive protein of angiotensinogen into angiotensin 1. Then angiotensin 1 travels through the bloodstream into the lungs where it encounters that ACE enzyme. It's converted into angiotensin 2, and then that's where all the magic happens. That's the last slide, but there's at least 4 things that we can mention that all act on either increasing blood volume, retaining water, drinking more water, retaining sodium, or increasing blood pressure, like constriction of the blood vessels, or just increasing cardiac output. Okay. There is another PowerPoint on blood vessels, and I don't know that it's really different than what we saw at the end of our last lecture. I'll make these available if we want to find some of these blood vessels in lab. I will say there's a couple of slides that I like, and I wanted to point out some of the differences. There was one thing that I drew on the board last time where I was trying to draw the drainage of the veins. Maybe this is a better picture. There's one of those torso models that shows we've got our superior vena cava that goes up. Remember, there is a vein that goes to the left and to the right. These are the brachiocephalic veins. There's our right brachiocephalic vein and our left brachiocephalic vein. If we follow those brachiocephalic veins up, they split into an internal jugular and a subclavian vein. I wish we could maybe zoom in a little bit on this one, but you can see there's a lighter shade of blue that is just to the lateral side of the internal jugular. That's our external jugular. I believe we found it on the models last time. If we need to find it again, I'll be glad to jump back there. The other thing that we see in the arm, I pointed this out on that flat blood vessel model in the corner. There are superficial veins that we need to know that run down the arm. The one that runs down the thumb side of the arm is what we call the cephalic vein. Here we are. Cephalic vein, let me go to the right slide. This is the one that runs down the thumb side of the body. And then there's another superficial vein that runs down the pinky side of the arm. And that's going to be what we call the basilic vein. So basilic vein, cephalic vein. There's the median cubital vein that connects the basilic and cephalic. It's what you would use if you're trying to draw blood from somebody. The other one that you see on the model is the median antebrachial vein. I don't know that that one made the lab list. But I just wanted to point out these superficial veins. I think I did that on that flat model. The other one that's on the flat model is this great saphenous vein that runs down the medial side of the leg. I don't know that I want to erase this diagram, but let me draw something. I'll keep those diagrams up. I'll just move this out of the way. I'm just going to have to deal with these little spacers in there. I'm going to act like they're not there. But let's put, I'm going to put up here the liver. And I'll put a couple of other boxes here. I'm going to put this box that is going to represent the distal part of the small intestines. Come down here. So small intestine and ascending colon. It's going to be represented by this box, and then there's another box down here that I will let represent the distal part of the colon. So we'll say descending colon and sigmoid colon. So the distal end of the colon and the rectum will be represented by this box. And then we'll just keep it the same color. I'll let this represent the spleen. All right. On our lab list, we have to know a vein called the splenic vein that's going to be taking blood. Maybe these arrows can just show the splenic vein. Drains blood from the spleen. It's going to take it over towards the liver. There is a vein that is going to drain blood from the descending colon and the rectum. This vein that drains blood from that area is what we call the inferior vena cava. Let me try that again. There's another mistake that I made. Inferior mesenteric vein. Those are not even close. I don't know how I said that. Inferior mesenteric vein. Draining the descending colon and the rectum. We're going to see draining the small intestines and the ascending colon is going to be a blood vessel that we call the superior mesenteric vein. So hopefully that's obvious. Notice how the inferior mesenteric vein, when it runs into the splenic vein, we still just call this the splenic vein. But that's not going to be the case when the superior mesenteric vein and the splenic vein come together. From that point on, I'm going to try and draw this in a little bit thicker vessel. Obviously not the best artist there, but this thing that's now taken blood from the small intestines, from the colon into the liver, this is our hepatic portal vein. I wanted to draw it because this is the only other portal vein that we see in the body. We said a portal vein is going to connect two capillary beds. So we've got capillary beds in the small intestines and the colon. Blood from those capillary beds is being drained and fed into the capillaries of the liver. So we'll see what come out of here are called hepatic veins. But this hepatic portal vein is going to take blood to the liver. We're going to draw liver tissue and we're going to see hepatic portal veins, hepatic veins, and hepatic arteries. I don't know, I think that's unit 4 as well. But in terms of veins, I wanted to show on one of those pancreas models, we were pointing this out in lab and I didn't draw that on the board. But this thing, I'm sure we'll show back up on the practical. You've got the spleen on one end, and if you flip this thing around to the back, they're using a purple color for all of these, but you can see the splenic vein that goes from the spleen into this hepatic portal vein, and you see the other two veins. One is the inferior mesenteric vein, and then this one with a number 7 on it is the superior mesenteric vein, where superior mesenteric vein and splenic vein merge. From that point on, it gets a different number here, and that's our hepatic portal vein. Again, blood vessel stuff. So with our lecture done and me already talking about blood vessels in the lab, I will stop my lecture and open it up to any kind of questions about this stuff or hunting down blood vessels from lab last time. I know I've erased the to-do list, but that has officially gotten us through our capillary exchange discussion. It's really knowing these 4 forces, which ones favor and which ones oppose filtration, how these numbers change, which numbers change really, as we go from the arterial to the venule end. It's really just the pushing force. We get further away from the heart. And when this pushing force, when that number drops below the pulling force, now reabsorption dominates over here at the venule end.